Welcome to the Dr. Izzy's Medical Podcast channel.
Chronic myelogenous leukemia. Chronic myelogenous leukemia, CML, also known as chronic myeloid leukemia, is a cancer of the white blood cells. It is a form of leukemia characterized by the increased and unregulated growth of myeloid cells in the bone marrow and the accumulation of these cells in the blood. CML is a clonal bone marrow stem cell disorder in which a proliferation of mature granulocytes, neutrophils, eosinophils and basophils, and their precursors is found. It is a type of myeloproliferative neoplasm associated with a characteristic chromosomal translocation called the Philadelphia chromosome. Signs and symptoms. The way CML presents depends on the stage of the disease at diagnosis, as it has been known to skip stages in some cases. Most patients are diagnosed during the chronic stage, which is most often asymptomatic. In these cases, it may be diagnosed incidentally with an elevated white blood cell count on a routine laboratory test. It can also present with symptoms indicative of hepatosplenomegaly and the resulting upper quadrant pain this causes. The enlarged spleen may put pressure on the stomach, causing a loss of appetite and resulting weight loss. It may also present with mild fever and night sweats due to an elevated basal level of metabolism. Some are diagnosed during the accelerated stage, which most often presents bleeding, petechiae and ecchymosis. In these patients, fevers are most commonly the result of opportunistic infections. Some patients are initially diagnosed in the blast phase, in which the symptoms are most likely fever, bone pain and an increase in bone marrow fibrosis. Risk factors. CML is more common in males than in females and appears more commonly in the elderly, with a median age at diagnosis of 65 years. Exposure to ionizing radiation appears to be a risk factor, based on a 50-fold higher incidence of CML in Hiroshima and Nagasaki nuclear bombing survivors. The rate of CML in these individuals seems to peak about 10 years after the exposure. Diagnosis. CML is often suspected on the basis of a complete blood count, which shows increased granulocytes of all types, typically including mature myeloid cells. Basophils and eosinophils are almost universally increased. This feature may help differentiate CML from a leukemoid reaction. A bone marrow biopsy is often performed as part of the evaluation for CML, and CML is diagnosed by cytogenetics that detects the translocation, chromosome 9 and chromosome 22, which involves the ABL1 gene in chromosome 9 and the BCR gene in chromosome 22. As a result of this translocation, the chromosome looks smaller than its homologue chromosome, and this appearance is known as the Philadelphia chromosome chromosomal abnormality. Thus, this abnormality can be detected by routine cytogenetics, and the involved genes BCR-ABL1 can be detected by fluorescent in situ hybridization, as well as by PCR. Controversy exists over so-called pH-negative CML, or cases of suspected CML in which the Philadelphia chromosome cannot be detected. Many such patients in fact have complex chromosomal abnormalities that mask the chromosome 9 and chromosome 22 translocation, or have evidence of the translocation by FISH or RT-PCR in spite of normal routine karyotyping. The small subset of patients without detectable molecular evidence of BCR-ABL1 fusion may be better classified as having an undifferentiated myelodysplastic, myeloproliferative disorder, as their clinical course tends to be different from patients with CML. CML must be distinguished from a leukemoid reaction, which can have a similar appearance on a blood smear. Classification. CML is often divided into 3 phases based on clinical characteristics and laboratory findings. In the absence of intervention, CML typically begins in the chronic phase, and over the course of several years progresses to an accelerated phase and ultimately to a blast crisis. Blast crisis is the terminal phase of CML and clinically behaves like an acute leukemia. Drug treatment will usually stop this progression if started early. One of the drivers of the progression from chronic phase through acceleration and blast crisis is the acquisition of new chromosomal abnormalities. Some patients may already be in the accelerated phase or blast crisis by the time they are diagnosed. Chronic phase. Approximately 85% of patients with CML are in the chronic phase at the time of diagnosis. During this phase, patients are usually asymptomatic or have only mild symptoms of fatigue, left side pain, joint and/or hip pain, or abdominal fullness. The duration of chronic phase is variable and depends on how early the disease was diagnosed as well as the therapies used. In the absence of treatment, the disease progresses to an accelerated phase. Precise patient staging based on clinical markers and personal genomic profile will likely prove beneficial in the assessment of disease history with respect to progression risk. Accelerated phase. Criteria for diagnosing transition into the accelerated phase are somewhat variable. The most widely used criteria are those put forward by investigators at MD Anderson Cancer Center and the World Health Organization. The WHO criteria are perhaps most widely used, and define the accelerated phase by the presence of greater than or equal to one of the following hematological cytogenetic criteria or provisional criteria concerning response to tyrosine kinase inhibitor therapy. Hematological and cytogenetic criteria are persistent or increasing high white blood cell count, greater than 10 times 10 to the power of 9 liter, unresponsive to therapy. Persistent or increasing splenomegaly, unresponsive to therapy. Persistent thrombocytosis, greater than 1000 times 10 to the power of 9 liter, unresponsive to therapy. Persistent thrombocytopenia, less than 100 times 10 to the power of 9 liter, unrelated to therapy. Greater than or equal to 20% basophils in the peripheral blood. 10-19% blasts in the peripheral blood and or bone marrow. Additional clonal chromosomal abnormalities in Philadelphia chromosome-positive cells at diagnosis, including so-called major route abnormalities, complex karyotype, and abnormalities of chromosome 3q26.2. Any new clonal chromosomal abnormality in Philadelphia positive cells that occurs during therapy. Provisional response to tyrosine kinase inhibitor criteria. Hematological resistance to the first tyrosine kinase inhibitor. Any hematological, cytogenetic, or molecular indications of resistance to two sequential tyrosine kinase inhibitors. Occurrence of two or more mutations in the BCR-ABL1 fusion gene during tyrosine kinase inhibitor therapy. The patient is considered to be in the accelerated phase if any of the above are present. The accelerated phase is significant because it signals that the disease is progressing and transformation to blast crisis is imminent. Drug treatment often becomes less effective in the advanced stages. Blast crisis. Blast crisis is the final phase in the evolution of CML, and behaves like an acute leukemia, with rapid progression and short survival. Blast crisis is diagnosed if any of the following are present in a patient with CML. Greater than 20% blasts in the blood or bone marrow. Treatment in CML. The only curative treatment for CML is a bone marrow transplant or an allogeneic stem cell transplant. Other than this, there are four major mainstays of treatment in CML: treatment with tyrosine kinase inhibitors, myelosuppressive or leukapheresis therapy, splenectomy, and interferon alpha-2b treatment. Due to the high median age of patients with CML, it is relatively rare for CML to be seen in pregnant women. Despite this, however, chronic myelogenous leukemia can be treated with relative safety at any time during pregnancy with interferon alpha hormones. Chronic phase. In the past, antimetabolites, for example, cytarabine, hydroxyurea, alkylating agents, interferon alpha-2b, and steroids were used as treatments of CML in the chronic phase, but since the 2000s have been replaced by BCR-ABL tyrosine kinase inhibitors, drugs that specifically target BCR-ABL, the constitutively activated tyrosine kinase fusion protein caused by the Philadelphia chromosome translocation. Despite the move to replacing cytotoxic antineoplastics with tyrosine kinase inhibitors, sometimes hydroxyurea is still used to counteract the high leukocyte counts encountered during treatment with tyrosine kinase inhibitors like Imatinib. In these situations, it may be the preferred myelosuppressive agent due to its relative lack of leukemogenic effects and hence the relative lack of potential for secondary hematologic malignancies to result from treatment. Imatinib. The first of this new class of drugs was Imatinib mesylate, approved by the U.S. Food and Drug Administration in 2001. Imatinib was found to inhibit the progression of CML in the majority of patients sufficiently to achieve regrowth of their normal bone marrow stem cell population with stable proportions of maturing white blood cells. Because some leukemic cells persist in nearly all patients, the treatment has to be continued indefinitely. Since the advent of Imatinib, CML has become the first cancer in which a standard medical treatment may give to the patient a normal life expectancy. Dasatinib, nilotinib, Raditinib, and Bosutinib. To overcome Imatinib resistance and to increase responsiveness to tyrosine kinase inhibitors, four novel agents were later developed. The first, dasatinib, blocks several further oncogenic proteins, in addition to more potent inhibition of the BCR-ABL protein, and was initially approved in 2007 by the US FDA to treat CML in patients who were either resistant to or intolerant of Imatinib. A second new TK inhibitor, nilotinib, was also approved by the FDA for the same indication. In 2010, nilotinib and dasatinib were also approved for first-line therapy, making 3 drugs in this class available for treatment of newly diagnosed CML. In 2012, Imatinib joined the class of novel agents in the inhibition of the BCR-ABL protein and was approved in South Korea for patients resistant to or intolerant of imatinib. Bosutinib received US FDA and EU European Medicines Agency approval on September 4, 2012 and March 27, 2013 respectively for the treatment of adult patients with Philadelphia chromosome-positive chronic myelogenous leukemia with resistance or intolerance to prior therapy. Treatment-resistant CML. While capable of producing significantly improved responses compared with the action of imatinib, neither dasatinib nor nilotinib could overcome drug resistance caused by one particular mutation found to occur in the structure of BCR-ABL1 known as the T315I mutation. Two approaches were developed to the treatment of CML as a result. In 2007, Cytogenetic released results of an open-label phase 2-3 study that investigated the use of a non-BCR-ABL targeted agent omecytaxine, administered subcutaneously in patients who had failed with imatinib and exhibited T315I kinase domain mutation. This is a study which is ongoing through 2014. In September 2012, the FDA approved omecytaxine for the treatment of CML in the case of resistance to other chemotherapeutic agents. Independently, Ariad Pharmaceuticals, adapting the chemical structures from first and second generation TK inhibitors, arrived at a new pan-BCR-ABL1 inhibitor which showed efficacy against T315I, as well as all other known mutations of the oncoprotein. The drug, Imatinib, gained FDA approval in December 2012 for treatment of patients with resistant or intolerant CML. Just as with second-generation TK inhibitors, early approval is being sought to extend the use of Imatinib to newly diagnosed CML also. Vaccination. In 2005, encouraging but mixed results of vaccination were reported with the BCR-ABL1 P210 fusion protein in patients with stable disease, with GM-CSF as an adjuvant.
Thank you for listening Dr. Izzy's medical podcast series. If you want to support this project, please subscribe the channel and like this video. Thank you.